and he's here to share some pertinent information with you. Please feel free to take notes into your career journal and ask questions when appropriate. Okay? Thank you very much.
Thank you very much, Ms. Clark.
Feel free to take notes. Feel free.
And from my perspective, I'll leave it up to all of you, but obviously Ms. Clark sets the ground rules here. So if this is something that might have a few test-worthy questions within it, I'll leave it for her to decide. Good morning, everyone. First of all, may I ask, can you hear me okay?
Yes.
Okay, very good. And I hope the pyrotechnics, the slides are reasonably clear as we go along. I'm going to talk and I hope share and I hope have some interactions with all of you over the next, we have just under an hour, Ms. Clark? Or
25 is already for lunch.
You got it. How about if we shoot for a 12:20 ending so as to let you do anything you need to before the class ends, or if that's okay? Great. Please feel free to interject at any time as we go through this material. I was provided some objectives that included both discussion about career opportunities as well as some clinical overview of how blood products are used, how blood cells form, and basically just a juxtaposition of all these things. So again, please feel free to ask any questions or make any comments. Can I ask you, is there a clicker or a remote or? Oh, that's okay. I can go ahead and just advance from here.
I can click for you.
Are you sure?
Yeah,
Thank you. Thank you. That'll make it easier so I can walk around a little bit and actually look at people as I speak with you. Our discussion topics are listed here. I'm going to tell you just a little bit about blood source vis-a-vis this being one employment opportunity for people interested in hematology, phlebotomy, and other related fields. Discussing some medical careers where I work, a little bit about some educational positional requirements in order to work in the field, and then I'd like to go through some basic hematology as well as clinical medicine. We'll finish up with some final musings and Q&A at any time during this next 45, 50 minutes. Next slide, please. So a little bit about blood source. Next slide, please. This shows where we originally were founded in a water tower in the Midtown Sacramento area, about 15 miles south of here, almost 70 years ago. We now work out of the Rancho Cordova region, a business park, part of the former Mather Air Force Base. For those of you familiar with the VA hospital in Mather, Rancho Cordova, we're just across from it. Next slide, please. A little bit about us. We're community-based, so certainly all of the blood being transfused locally is provided by donors such as perhaps some of you as well as I. We're not for profit. That's not to say that for-profit businesses are wrong or evil, but we believe in healthcare that not-for-profit is generally the best approach. All of our donors give blood voluntarily. We do not coerce them, nor do we pay them. A little bit more information is listed here. I might just focus on the fact in the bottom left that we actually serve. We provide all the transfusion required blood products for about 5 million residents. So as you can imagine, that's not an inconsiderable number of people across our region. Next slide, please. I want to tell you just a little bit about how we collect and manufacture blood products. I think that will make our later discussion of blood cells, I was told to talk a little bit about the basic production of blood cells in our marrow, a little bit more alive, if you will. So one way that we can collect blood is by allowing whole blood to flow right from a donor's vein into a bag. You can see that it's measured for weight as we collect, and you see in the far right picture that the whole blood, about 500 mils, that's about a pint, is separate from several empty bags into which we're going to move different blood components. I'll show you right now. Next slide, please. So pure and simple, we take that whole blood and we spin it under a centrifuge. Are you all familiar with how centrifuges work? If not, I can explain briefly, or is this something that you've covered already? Then that's okay. So briefly, a centrifuge spins whatever it is that you're trying to separate into different components. And has anyone ever ridden in one of those amusement park rides like a big carousel where you put your back to the wall and it starts to spin and you feel the gravitational force actually pulling you against the back of the wall? Maybe some of you have, some of you can imagine that. It's a similar concept here where we actually separate out the red cells, almost like you up against that wall, down to the bottom of the bag as we spin it within that big washing machine-sized centrifuge, and we can separate red cells from other parts of the blood. Next slide, please. So we take that whole blood unit depicted in the top left, we separate it, shown as in the bottom left, into red cells that can be given to patients, plus platelet-rich plasma. And we're going to talk about what all that means. Are you a little bit familiar already with red blood cells, platelets, and plasma? And if not, that's okay, because today might be a first introduction. Have you had a little bit of overview of that, or not quite yet? Good, good. No, this is great. I love it. We'll talk a little bit more about what we do with all these products in the next slide. So one of the products we create also is plasma. You've probably heard of it before in various contexts. One context that this doesn't apply to is like a plasma television, very different thing. We're talking about plasma, which is the liquid portion of blood. That's the stuff that allows blood to clot, as it should. What do we want to happen if we scratch ourselves up against a rose bush? Do we want it to just keep bleeding and bleeding? Obviously not. We want normal clotting, a scab to form, so as to stop that blood loss. And that's what plasma is largely responsible for doing. Platelets also perform a similar role, as we'll discuss. We can take that plasma and transfuse it into patients, such as trauma patients, thousands of units transfused every month locally, or we can make it into another substance called cryoprecipitate. I won't go into the gory detail other than to say that this cryoprecipitate is almost like a glue. It's what allows wounds to clot, to stop bleeding, allows the patients to survive. Next slide, please. So let's talk just a little bit more about one other way we collect blood. Remember a moment ago I told you that, and by the way, show of hands, anybody here yet donated blood? Super, super. I see a few people. And for those of you who haven't, that's okay. We don't coerce anybody. But if you would like to try it, if it's for you, certainly we do periodically have blood draws in the area. Long story short is, as you know, both of you ladies, we do collect again that 500 mils, about 2 cups of blood, and manufacturing and all the good stuff I just talked about. Another way we can collect blood is by literally hooking up a blood donor to a machine. And what that allows us to do is to use that centrifuge I just spoke about right at the time of the collection to collect very specifically the types of products we need. Now, why is it so important that we collect blood? I know you folks understand the basic principles. Patients would die without it. I'll tell you one example of a patient I was working with just last night. He was a very young, I'm not going to give too much detail because it's possible that that somehow could link back to the identity of the patient. I don't want to respect that. I'll just say a very young patient, younger than any of you in the room, African-American child with sickle cell disease, who was having severe problems bleeding. And the only way we could actually save or help to save his life was by giving him multiple units of blood. Otherwise, he literally was going to die right in front of his parents and the doctors treating him. In this case, as it turns out, while normally we don't care at all what the race or ethnic identity of the donor is, usually it just doesn't matter. White, black, brown, whatever, it's just not an issue. But in this case, we actually specifically needed donors who were more alike to him genetically, in this case, fellow African-American donors whose blood cells were more likely to survive in a circulation because he had been immunized based upon past transfusions to antigens. Are you familiar with antigens from immunology? Or not quite? Okay, that's okay. He had been immunized to foreign substances on the cells of other blood donors, and this required that we find donors as genetically similar to him as possible. And fortunately, we had, as it turns out, a recent drive at a church in a local African-American community who had given a whole lot of units, and we found just enough of those units in order to match his type. We were lucky. That's one example of the importance of having blood available and making sure that we have blood from people of all racial and ethnic groups. Again, it usually doesn't matter. Wouldn't matter if I needed blood in most cases what the racial or ethnic identity of that donor was, but in rare circumstances it does matter. I'm going to keep going. Any questions so far? Next slide, please. So we literally can collect many components using apheresis, that glorified centrifuge, from, in this case, a gentleman from World War II era. This picture was taken about 10 years ago. What does it tell us, though? So many of our donors are older, and they're wonderful, but they're older, they're primarily Caucasian. We want more and more to have our blood donor population represent our entire country, including younger people and people of all racial and ethnic groups. By the way, this gentleman gave over 1,000 times before he stopped donating, if you can imagine that. Wonderful gifts to society, many, many hundreds of patients saved. But he's no longer donating. We need somebody to take his place. Next slide, please. One of the products we were collecting from him was what are known as platelets. Did any of you, have you heard the story of the little Dutch boy who stuck his finger into the hole in the dam in order to stop the dam from overflowing the town below? It's an old story, so I see one person nodding though. Long story short is the platelets are like that little Dutch boy who stuck his finger into the dam, into the hole in the dam, stopped the bleeding, if you will, or the rush of water from coming through. Platelets plug holes and help form that scab that stops bleeding. Next slide, please. This gentleman here actually, and I can share his name with approval from him and his family, Mr. Ray Yang, when he stopped donating only because he passed away unexpectedly in his late 80s, he had given over 1,700 donations. This gentleman actually had been a former World War II concentration camp detainee in our country, and internment camp, and yet still he thought enough about others despite everything he went through to give back. He also was a veteran of our U.S. military. Just a wonderful man. Imagining 1,700 donations. Next slide, please. Good friend. What he was giving at that time was plasma. I talked about it earlier. Remember, that's the liquid portion of the blood. You notice it ain't red. It's yellow. That's because the red cells have been removed from it. It's got all the clotting factors that, again, support stopping bleeding. Next slide, please. By the way, one last thing I'll share as we conclude this part of the discussion and go into a little bit more career interlude, if you will, is that any extra products we have, well, long story short is we don't waste nothing. Any extra products we have, we use whether it's for appropriate research that has been approved by donors, or whether it's to manufacture different medications. And for example, any extra plasma we don't actually transfuse directly into patients gets made into immune globulins that can be injected into people in order to allow their immune systems to function normally, as well as other substances. I won't go again into all the excruciating details other than let you know that there are literally thousands of different proteins in our bodies, and blood donors, with our help, can help replace the proteins that people are missing. Any questions or comments so far? I'm going to stop for a moment, and anything is fair game. Well, if anything comes to mind, just say the word. So, continuing, and I don't want to block the screen here, come over to this side. So, when we give blood, and I'm not so sure using a gun analogy is the best one to use, but it does fit. We have a couple of approaches we can use. I work in many parts of Africa, in developing countries, and in Africa, often all they have is whole blood to use. In other words, the stuff that was collected fresh from the donor, sometimes still steaming warm. If that's all you got, that's what you give. You don't let a patient die just because you don't have the perfect. You don't let the perfect get away in the good, right? But where possible, we again try to separate that whole blood, which is depicted on the left image, into, as shown on the right image, all different components and substances so that we can give that patient only what he or she really needs and save the rest for somebody else. Does that make sense? So long story short is I'm thinking of one classic example. When I was in Kigali, Rwanda a few years ago, working with some wonderful people who were trying to figure out how to take care of patients with, in this case, hemophilia. You may or may not have heard of hemophilia before. It's a clotting disorder where patients literally can bleed to death because they don't have normal clotting. They brush against that rose bush and they just keep bleeding. They don't scab over. So long story short is that a lot of children, almost exclusively male children, it's a disease that affects men far more often than women, were dying needlessly because special products weren't available to treat them. And friends and colleagues in Kigali, Rwanda mentioned to me that they would like to have a way of making special components from whole blood that would allow them to save at least some of these patients. And sure enough, that's what they did. It was very exciting to watch them do it. I just provided a little bit of technical assistance. They did all the hard work. And one more reason why it was exciting is probably all of you are familiar with the genocides that occurred in Rwanda with the Hutus and the Tutsis back in the late 90s. And it's just neat to see that a country that was so ravaged by terrible events is coming back, turning things around. Next slide, please. So with that in mind, we do work all over the world through a combination of both volunteer and contracted work. Most of our work, as depicted in this map, has been in sub-Saharan Africa. We've also worked a lot in the former Soviet Union. A number of cumulative years spent on the ground. Next slide, please. This is an example. These are examples of the kinds of patients who've benefited from the kind of work our colleagues in these countries and we have done. I'll tell you one more quick story about the importance of blood. My first trip over to Kenya was in 2004. I was the doctor visiting a number of rural hospitals out in the boundaries of the country. And I still remember being led immediately upon arriving at one of the hospitals to one of the clinics where a child obviously was dying, about a 14-month-old, with his father and mother there. And I was asked to examine the child, and I'm thinking to myself, well, I'm happy to do this, but the child has excellent African doctors there, Kenyan doctors, who were able to take care of this child's needs far better than I could. So I was almost a little embarrassed, feeling like a fraud, but I was a doctor from the United States, so they, thought, oh, doctors from the United States must be able to do something. That's obviously, it was kind of them to feel that way, but their own doctors were better trained to help in this circumstance than I was. In any event, here's what I saw with this 14-month-old. The father handed him to me. And to this day, I often recall, sometimes before falling asleep, that this child, first of all, I could feel the heartbeat as I was holding parts of his body far away from the heart. It was just like a butterfly, practically. It was beating so fast. I looked at the child, first of all, looked at the sclera of the eye, and then the subconjunctiva, what should be pink right around the eye. This child, who was very dark-skinned, Kenyan, had practically white, almost as white as the frosting on your cookies, subconjunctiva. Now, any of us, regardless of our skin color, should have healthy pink tissue there, right? And the reason why we do is because we have enough red blood cells in our bodies. Well, this child, as it turns out, was missing about 95% of his normal allotment of red cells. And you may or may not be aware that red cells are what are required to carry oxygen throughout the body. Because of that, his heart was having to strain, pumping far more blood through the body, far more rapidly than otherwise would be necessary, just to move the little bit of oxygen his small quantity of red cells could move. It was clear to me that this child needed a transfusion very rapidly. In fact, a number of transfusions. Unfortunately, they weren't immediately equipped to do so. We were bringing the equipment that next day, but unfortunately, this child died within an hour, and I still think to myself how, no child should die from lack of a transfusion. It doesn't occur in the United States. It shouldn't occur anywhere in the world. Aside from being a very sad instance, it also just reminded me of how precious and fortunate we are to have blood donors who provide for patients like these. This, by the way, was a happy story. Next slide, please. The baby on the top actually got a blood donation from his father with some materials that some colleagues from, in this case, were in Nigeria, not far from Abuja, Nigeria, and this baby or toddler survived. Next slide, please. So I'm going to stop for a moment before talking a little bit about medical careers. Any questions or comments? Next slide, please. So where I work, I consult often at hospitals, but my main job is at BloodSource, which, as you already know now, is your local blood provider for transfusion purposes. And these are the kinds of jobs we have. People who draw the blood are phlebotomists. Our laboratory colleagues, boy, I hate it when I have typos, laboratory technicians and assistants. And those people who work in the lab as actual scientists. These are professionals, clinical laboratory scientists. They're the ones who do all the testing and the manufacturing of blood products. We also have many different nurses, both LVNs and RNs, and then several physicians. And long story short is we have over 500 people who are responsible not just for collecting and making the blood, but also for making sure it's appropriately used at the hospitals. Before I leave this, any questions? Do people know what some of the basic responsibilities of some of these positions are? Or do you want to know anything more about any of them? And that's okay. By the way, quick question for y'all. What grades do you all represent, please? 11th? The full continuum? Great, great. And a quick question for you as well, if I might just sort of transition for a moment. What are the kinds of careers that people are thinking of entering? Is it sort of a broad gamut of different options? When you, if you don't mind, shout out a few. You, miss? Yes, what are you considering? I'm sorry, what? Great, great. And thank you. Others? You, sir? And
I haven't really decided.
Still, that's okay. I didn't decide until well into college. Yes, please.
An RN.
Yeah, beautiful. Boy, we need RNs. Absolutely critical. A couple of other people. Anybody else considering something else? Yes, please.
Diagnostician or pediatrician.
I'm sorry, diagnostician or?
Pediatrician.
Pediatrician, wonderful. Working with the children, so important. There's a great, great need for that. They're often the patients who are least represented because, you know, some of them can't even talk, the babies, and the ones who can talk, they don't vote, obviously, so they don't, you know, they don't necessarily have a voice at the decision-making table, so it's so important people take care of them. Okay, well, why don't we continue, but anything at all you want to discuss, just interject anytime. A little bit about educational and position requirements, and I'm just going to talk to this slide. Long story short is it just depends upon what you want to go into. So for instance, as an RN, there are different avenues you could take, as you probably well know. One is you could, if you wish, go right into a training program that does not necessarily require you to get a 4-year college degree. If you wish to do through some of the community colleges a 2 or 3 year training program and still be a full RN, that's a wonderful way for many people to start. Another approach, though, is to get your bachelor's degree, your 4-year college degree at the same time, or even your master's. And then there are a lot of different other approaches you can explore. Any thoughts about maybe which approach you might wish to take?
My parents want me to go to a private college and get everything done, but I don't really want to do that. I just want to go to a good community college, just take my time.
You want to get the ball rolling, huh? But do it your way. Understand? And that's an excellent way to pursue. And you also, certainly that's going that route and then working the rest of your career in all different exciting and fulfilling positions is a wonderful way to go. You may a few years down the line say, hey, I'd like to get my bachelor's degree or get my master's degree and sort of supplement what I've already learned. You got different approaches you could take. Might ask a pediatrician, so as you know, you would be talking about going the medical school route. Would you like to do perhaps, there are different ways you can do it. Most people do 4 years of undergraduate school, college, and then 4 years of medical school. But there are some combined programs too that take 6 or 7 years combined. Are you thinking the more traditional 4 and 4, or?
So far, I'm looking at 4 and 4,
Okay.
just because it's what's closer to you.
Yep. Gives you a chance to appreciate some other things during college life and not focus just on medicine, which I think is a great idea. For hematology, if you thought about how you might like to pursue that path? Yep. Now, hematologists, and I work with many of them in our local community, it's an exciting career. So yes, it is. It's 4 and 4, like you said, 4 of college, 4 of medical school, and then typically 3 more years of internal medicine, as you know, obviously, and then 2 or 3 more years of hematology oncology training. So it would be an exciting career. I did some training in that area. I'm actually a pathologist by training, so I did 4 and 4. I went to UCLA School of Medicine, and then did 5 years of residency in pathology. But I like patients. I don't want them just, I didn't want to do autopsies all my life. Forget about that. But I wanted to work with patients, so I did some hematology training. But I'm not a hematologist. I'm a pathologist. So maybe someday we'll work together if I'm working in the career long enough when you're done. Any other comments about careers, questions, concerns? Okay. Well, tell you what, why don't we do a little basic hematology, speaking of hematologists. Next slide, please. So I'm going to ask you a quick question from this slide. If you were to guess, and I realize that you're still in the process of learning some of this material, but if you were to guess which of these 2 bone marrows you would rather have within the middle of your long bones, your ribs, your chest cage, etc. This is what's inside all of us in the middle of some of our bigger bones. Would you prefer the one on the left or the one on the right? And don't worry if you get it wrong. Just tell me what you think. How many people would prefer the one on the left? I'm seeing 1 hand, 2, seeing a number of hands. And how many people would prefer the one on the right? And I'm seeing some hands too here, so kind of equal splattering or splaying. Well, let me tell you which it is actually. As it turns out, actually, it's neither. And my apologies. I don't usually like to trick my friends in the group, but let me explain for a moment. The one on the left, can you see those pink, what we call spicules? Those are pieces of bone. And can you see how in between there's just very little material? Just sort of a bunch of wispy scaffolding. What that means is that there are no blood-producing cells whatsoever in the marrow on the right. The problem with that is that that person is not making red blood cells, not making platelets, not making white blood cells. And without treatment, and even with treatment still, is likely to die very quickly. The marrow on the left, by contrast, while it has lots of cells in it, some of these cells are not the kinds of cells we want, are actually cells that are cancerous, malignant. In fact, there are too many cells in that particular marrow. Potentially this individual too could die from this pattern. It's kind of the Goldilocks principle, where you don't want too little, you don't want too much, you want just right. And certainly I would expect if we were to look at our own marrows, most, and I hope all of our marrows have probably about 50% of the field filled with good healthy cells, making fresh blood cells every day. Next slide, please. Let's put this in a little more perspective. You see that little round cell at the very top of the image there? What's called a multipotent hematopoietic stem cell. That's the cell that hasn't decided what it wants to be when it grows up. If you will, that's the cell that ultimately can differentiate in all of the, down at the very bottom of this image, all of the cells in our blood and body that allow for us to breathe normally, to resist infections, and not to bleed to death. So let me explain what I mean briefly. You see how the arrows ultimately connect from that one cell at the very top, in some cases through multiple arrows, down to all the different cells at the bottom of this slide. So what's happening is that original cell, that multipotent stem cell, is differentiating. It's becoming more and more advanced, more and more committed to what kinds of blood cells it's ultimately going to make. Can you see on the far left that big cell called the megakaryocyte, that biggest one? It's almost shaped like a water balloon. That's the one that actually makes platelets. They're called thrombocytes there, but the name we use in the United States is platelets. Those are the ones that fill the holes, sort of like the child's finger in the hole in the dam, and stop bleeding. Can you see the cell in the far right bottom called a plasma cell there? That's the cell that makes immune globulins, antibodies, that can actually help prevent and treat infections within us. And then all different other kinds of cells are listed here. I'm going to stop for a moment. Any question about this, the fact that all of the cells in our bloodstream ultimately are made by that multipotent cell. Now, there are lots of those cells in us, those multipotent cells. It's not as if there's just one working overtime like a queen bee in a hive, but relatively few in the big picture. There are far more of those more committed cells by thousands and thousands of fold. So we need those immature cells at the very top to keep making new ones and then making fresh committed cells. Yes, sir?
Can the top cell ever split?
Yes, great. Can it ever split? Yes, and in fact it does. It splits in two ways. That's a great question. One way it splits is by actually splitting into those more committed cells down lower in the slide. So that's one way it splits. But the other, I think you're probably talking about, is can it make two of itself? Split into two of itself? Yes, and it does that as well. And the reason why it's so important, and your question is excellent about its ability to split and form more of itself, is if that top cell were to turn in all those other cells and nothing were to replace it, well, within a matter of days to weeks and months, you wouldn't have any new cells being made because that top cell would no longer exist. So yes, it does self-reproduce. Any other questions or comments before I take you through a few picture slides? And I'll make this brief. You might find this especially interesting as a future hematologist. Next slide, please. So remember how we talked about how that multipotent stem cell becomes more and more mature? Well, this is the myeloblast, which is shown on the left. It's a cell in the blood. This is a slightly more mature cell, but it's not yet ready for prime time. It's not yet ready to do things in our bloodstream. And what do you notice when you compare that on the left to the cell on the right, the promyelocyte? You notice, are you familiar a little bit with cells, with the nuclei of cells and the cell membranes? Well, you probably notice that the nucleus of the myeloblast, shown on the left, the purplish substance that's surrounded by a little of light blue over in the bottom left and top right, you notice that it's kind of smooth and homogeneous. Whereas if you look over to the promyelocyte on the right-hand side, the nucleus is starting to get a little denser. You'll see more of what I mean in just a moment in the next slide. And let's actually go to the next slide, please. And by here, you're noticing that it's a little smaller, the nucleus. This is the promyelocyte still, that second cell. And as you go over to the myelocyte, as it becomes more and more mature, it's splitting into new, more mature cells. You notice how the nucleus is relatively smaller compared to the cytoplasm. Remember, the cytoplasm is what the nucleus is, what contains the nucleus. You notice the cytoplasm in the cell in the far right, that's the pink, light bluish with some purplish dots in it along the top of the cell. There's more of it, relatively speaking. So the nucleus is getting smaller and smaller. Why is this important? Because the cell is starting to decide how it's going to function. And here's what I mean by that. Next slide, please. You notice here, too, that the nucleus, relatively speaking, by the far right slide, where it becomes what's known as a metamyelocyte, it's not important that you remember all this terminology, but you notice it's even smaller compared to the cytoplasm. You notice now that it's very distinct. probably shown in the far right, that nucleus has about half the surface area of the entire cell. Lots more cytoplasm. Let's keep going for a moment. Next slide, please. So that's another example of a metamyelocele on the left. What do you notice on the slide to the right now? What does the nucleus look like? Is it still round and symmetric? No. It started actually to form some involutions. It started to, and as it's preparing to do its thing, and I'll explain what its thing is in just a moment. Next slide, please. Finally, when you look at what's known as a band neutrophil on the left and compare it to what's called a segmented neutrophil on the right, you can probably guess why it's called a band versus segmented. Band, it's just a sort of horseshoe-like band on the left. Segmented because actually as you look at the nucleus, it seems to be segmented into several little pieces. Well, that cell on the far right, that's the one that's ready to respond to infections. If you've ever had, and I don't want to be gross here, but for anybody, or grotesque, but for anybody who's ever had a whitehead pimple before, that's full of lots of those segmented neutrophils. They're white, they're what gives that color. If anybody's ever had another kind of infection where they've had a little bit of pus coming from it, those are largely the neutrophils that are whitish in color, giving it that look. Next slide, please. So in this case, I'm just going to very briefly go through and show you again. Here on the far left, you're looking at cells that are very primitive. They're closer to that multipotent stem cell that we talked about on the image a few moments ago. You see on the far right that the nucleus is starting to get tighter. There's more cytoplasm. Next slide, please. And if you go over to the far right here, you've got an actual plasma cell. You might remember from a few moments ago, that's a mature cell that makes antibodies. That's the cell that we have literally billions of in our bodies that makes the antibodies to protect us from infections and other problems. I'll give you just one more example here. Next slide, please. So here we're going to be looking at early red blood cells. And you might say, boy, that doesn't, actually let me give you a comparison. You see all those, don't look at the purple stuff for a moment on this micrograph, but you see all the pinkish blobs in the corners? Those are mature red blood cells. They don't have any nuclei in them. You don't see any purplish nuclei, right? You're just seeing pink blobs. They're packed full of hemoglobin. That's what carries oxygen throughout our bodies. That's the ultimate goal of these other big cells within. Can you imagine that those big cells